Bismillahirrahmanirrahim. Let us begin today's presentation with the dua from the Quran. رَبَّنَا آتِنَا فِي الدُّنْيَا حَسَنَةً وَفِي الْآخِرَةِ حَسَنَةً وَقِنَا عَذَابَ النَّارِ. Our Lord, give us in this world good and in the hereafter good, and protect us from the punishment of the fire. I am Dr. Naveed. I am consultant neurologist, Allied Hospital, Faisalabad. Today I will discuss with you Parkinson's disease. We will discuss the basics of Parkinson's disease, its etiology, pathology, then classification, then diagnosis and management of Parkinson's disease. Parkinson's disease is a progressive neurodegenerative disorder. It occurs due to depletion of dopamine producing cells in the specific part of the brain, that is substantia nigra. It's fairly common, one of the common neurologic disorders. 1% of the population more than 60 years of age is suffering from Parkinson's disease. Pathology of Parkinson's disease is marked by two findings. Number one, this is the normal brain. This is histology of substantia nigra with normal pigmented cells producing. These pigmented cells produce dopamine. This is normal histology. And this is histology from substantia nigra of a patient with Parkinson's disease. You can see the depletion of pigmented cells in this slide. And this is number one feature of Parkinson's disease. And number two feature is the presence of Lewy bodies in the cells, in the remaining cells of the substantia nigra. Cells are depleted, and then the remaining cells contain Lewy bodies that impair production of dopamine in the substantia nigra. The classification of Parkinson's disease, then pathophysiology of Parkinson's disease. Pathophysiology of Parkinson's disease, as I have already told you, that there is depletion of dopamine production in the brain. There are two pathways that cause our movements and that can produce dopamine. One is the direct pathway and other one is the indirect pathway. The ultimate result of these two pathways in Parkinson's disease is dopamine depletion. Then the classification of Parkinson's disease. Number one is idiopathic Parkinson's disease, that is called primary Parkinson's. It is called Parkinson's disease. When a secondary cause of Parkinson's disease is known, for example, drugs, there are few drugs that can cause Parkinsonism: toxins, a stroke in the basal ganglia region, hypoxic insult to the basal ganglia, or encephalitis or trauma to the basal ganglia could lead to Parkinson's. This will be called as Parkinsonism or secondary Parkinsonism. When there is no cause known, this will be called as Parkinson's disease. When there is a secondary cause to the Parkinsonism, then we will label the patient as Parkinsonism or secondary Parkinsonism. And then there are Parkinson plus syndromes, for example, progressive supranuclear palsy, Lewy body dementia, multiple system atrophy, corticobasal degeneration. We will discuss them in detail later on. This is the pathogenesis of Parkinson's disease. This is the gross morphology of midbrain showing substantia nigra in a normal person with the normal cells, and this is the morphology of substantia nigra in a Parkinson's disease patient. You can well appreciate the loss of pigment cells in the substantia nigra, and on the histology we can also appreciate the loss of pigmented cells in the substantia nigra. Neurodegeneration is the basic mechanism of Parkinson's disease. Neurodegeneration in Parkinson disease occurs due to a variety of factors. For example, environmental factors, aging process, genetic factors. All three lead to oxidative stresses, and that ultimately causes apoptosis of the cells. If apoptosis occurs in the substantia nigra, it will cause loss of dopamine, and if apoptosis occurs in other cell populations, the other neurotransmitters will also be affected. There are cardinal manifestations of Parkinson's disease, but before going to Parkinson's disease, or before Parkinson's disease, frank onset of Parkinson's disease, there are prodromal premotor symptoms that suggest that patient is going to have Parkinson's disease within 1 to 3 years. Number one is anosmia, impaired sense of smell. This is called anosmia. This is a prodromal symptom that occurs before the onset of frank Parkinsonism. Then depression and anxiety could be a precursor of Parkinson's disease. Aches and pains, especially frozen shoulder, this is also a prodromal symptom of Parkinson's disease. REM sleep disorders, autonomic features disturbances can occur. Restless leg syndrome can occur before the onset of Parkinson's disease. However, Parkinson's disease is marked by tremors, slowness of movements, stiff limbs, difficulty in fine movements, and spidery handwriting. These are the 4 cardinal manifestations of Parkinson's disease. Number one is hypokinesia. Hypokinesia is difficulty in initiating a movement. When a person is requested to walk, he takes time to start the walking. This is called hypokinesia. And then rigidity. Rigidity is increase in tone of the muscles. Then resting tremors, postural instability, leading to frequent falls. These are the 4 cardinal manifestations of Parkinson's disease. And let us briefly discuss these 4 manifestations in detail. Tremors in Parkinson's disease are of 3 to 6 Hz frequency. Tremors are typically pill rolling tremors. There are other tremors that should be differentiated. For example, essential tremors are of high frequency that does not occur at rest, that occur in the kinetic position. So it helps us in differentiating Parkinson's disease from other differentials. Rigidity is the stiffness felt throughout the range of the motion. Rigidity affects the both agonist and antagonist muscles. Rigidity in Parkinson's disease is of cogwheel type. Cogwheel means that there is jerky feeling to the tone. When the examiner is examining for the tone of the muscles, for example at the wrist, if there are superimposed tremors, then there will be jerky feeling to the tremors. Due to tremors, lead pipe rigidity may occur in Parkinson's disease if there are not tremors are absent in the patient. Bradykinesia is poverty and slowing of movements, difficulty in initiating the movements. Bradykinesia is assessed in the clinics by requesting the patient to rapidly tap the fingers. For example, patient is shown this movement and requested to follow this movement and asked to tap this index finger on the thumb with the big amplitude. In patients with Parkinson's disease, these movements will become slow and the amplitude of movement will become progressively shorter. Patient may also be, this bradykinesia can also be assessed in the heel tapping. Patient is asked to tap the heel over the floor, and this tapping will progressively become slower and the amplitude of foot elevation will become progressively slower. Then the postural changes leading to stoop posture, shuffling of the gait, decreased arm swing during movement, lack of facial expressions. This is called hypomimia or expressionless face. Frequent falls due to failure of corrective reflexes. That's a sign in late Parkinson disease. Earlier signs are bradykinesia, rigidity. Speech of the patient with Parkinson disease is monotonous in a single tone. Dribbling of saliva is a frequent feature. Dysphagia may develop as the disease worsens. This is the video of a patient showing examination of Parkinson's disease.
Sadie's kindly agreed to be involved in going to when she's on treatment. It will be evident. And there's a reduction in the arm flexed posture, mild hypomimia or expressionless.
Decreased arm swing
and there's a reduction in the arm swing, particularly on the right, but on both sides really. That's great. And if you could turn around and walk away from us again.
And the turning of the patient
take a number of steps more than is usually required.
And the face of the patient is
and the stride length is quite
These are the
low.
manifestations of Parkinson's
so
disease.
She's partially treated. And then turn around again, a few extra steps to
in
turn.
This patient.
And then come
Look
on back, thanks.
The patient once again, decrease arm swing, short
the
steps,
reduction in arm swing is the key thing in early Parkinson's. That's great. Thanks. You can just stand there for.
Then the diagnostic criteria of Parkinson's disease. Patient should be hypokinetic, hypertonic. Hypokinetic means bradykinesia. Hypertonic, there should be rigidity present on examination of usually cogwheel type. Unilateral beginning of the disease is essential. If disease onset is bilateral, symmetric, that's a feature of Parkinsonism or secondary Parkinson's. Unilateral onset is the rule of Parkinson's disease. Positive effect to levodopa. If a patient is suspected of Parkinson's disease, we give him a challenge of levodopa for a few days and see the improvement in the patient. If there is improvement, then the patient is labeled as case of Parkinson's disease. And the absence of postural instability, autonomic features at the early stage. These features, these disturbances do occur, but later, after 2 to 3 years of onset of Parkinson's disease. So postural instability, autonomic symptoms like urinary retention or urgency, cognitive disturbance or decrease in memory, if do occur early in the disease, that is a feature of Parkinson plus syndrome or secondary Parkinsonism. They occur later in Parkinson's disease, usually 2 to 3 years of onset of Parkinson's disease. How to diagnose a patient with Parkinson's disease? There are no lab tests available for the diagnosis. It is all clinical. We examine the patient in the clinic and for all the signs of bradykinesia, rigidity, posture reflexes, we assess for his cognition. And we need to rule out other causes that can present with a similar presentation of Parkinson's disease. Like hypothyroidism can present like Parkinsonism, Parkinson's disease, depression, certain drugs, if patient is using certain drugs, that could be Parkinsonism or secondary Parkinson's. Diffuse brain disorders can like Alzheimer's disease or multi-infarcts in the region of basal ganglia, repeated head injury in boxers like the famous Muhammad Ali Kale. He was suffering from Parkinsonism due to repeated injuries to the head. These are causes of secondary Parkinsonism. Drugs like neuroleptics, metoclopramides that act by depleting dopamine. That is the cause of secondary Parkinsonism. Then atypical Parkinsonisms like progressive supranuclear palsy, multiple system atrophy, corticobasal degeneration have their presentations. I will show you later on. Wilson disease, if a patient is less than 40 years of age and presents with the signs symptoms of Parkinsonism, then always consider Wilson disease. because Wilson disease is treatable and can present like extrapyramidal syndrome like Parkinsonism. Now, the treatment of Parkinson disease, these are the 6 types of drugs that are used in the treatment of Parkinson disease. How does these drugs act? I will show you. And the ultimate aim of all these drugs is to enhance dopamine in the substantia nigra on the central nervous system. A brief introduction to the dopamine metabolism in the brain. Dopamine is produced by tyrosine hydroxylase, that is an amino acid that is converted into levodopa by enzyme tyrosine hydroxylase. Then levodopa is converted into dopamine by dopa decarboxylase. This dopamine is then packed into the synaptic vesicles, and these vesicles are secreted into the cleft. And here dopamine acts on its receptors. Predominantly D1 and D2 receptors are involved in the Parkinsonism. And then the excess of dopamine is either it is degraded by catechol or methyl transferase into dopamine is degraded, or dopamine is these dopamines are moved into the presynaptic terminal. This is the mechanism of dopamine action and production. And then how does these drugs that are used in Parkinson's disease act? Dopamine cannot be taken orally because dopamine does not cross this blood-brain barrier. So its immediate precursor levodopa, that is that can cross the blood-brain barrier. Levodopa is given to the patients. Levodopa is taken, but the problem of levodopa is that levodopa is converted by decarboxylase enzymes in the peripheral circulation. It does not reach the brain. So we give the patients decarboxylase inhibitor, that is carbidopa, along with levodopa. So the combination that comes in the market is a combination of levodopa plus carbidopa to prevent its peripheral decarboxylation. So this decarboxylation is prevented. Levodopa reaches the central nervous system. Levodopa crosses the blood-brain barrier, and then levodopa is converted into dopamine. Then this dopamine is packed as into the vesicles, and these vesicles are secreted here. So number one drug is that is most beneficial for Parkinson's disease is this levodopa. This levodopa is given to the patients. Number two drug that is used for Parkinson disease is the dopamine that is secreted into the synaptic vesicle, and then this dopamine is degraded by MAO enzyme, MAOB enzyme. These MAOB inhibitors are given to the patient to prevent its degradation, so that dopamine remains in the synaptic vesicle for the maximum time. Number three drug that is used for Parkinson's disease are called dopamine agonists, that bypass all this mechanism and directly acts on the D1 and D2 enzymes. Those are called dopamine agonist drugs. So this is another diagram showing the mechanism of Parkinson drugs. Number one is levodopa, levodopa, and then decarboxylase inhibitors are given along with levodopa. This levodopa crosses the blood-brain barrier and reaches the nigrostriatal neuron, and here levodopa is converted into dopamine, and due to this decarboxylation, dopamine is secreted over here, and acts on the postsynaptic receptors or dopamine receptors. So number one drug that is the gold standard for levodopa. It's a prodrug of dopamine and that acts on its receptors, postsynaptic receptors. Dopaminergic agonists that I have shown in the figure are that act directly on D1 and D2 receptors. The commonly used ones are ropinirole, rarely bromocriptine, cabergoline, pergolide, apomorphine can be used. MAO-B inhibitors that prevent dopamine degradation. The common ones are entacapone and talcopone are used in the clinically. And then another class of drug, that is anticholinergic drugs, help in reducing tremors and rigidity. In brain central nervous system, there is a balance between dopamine and acetylcholine. Dopamine, if dopamine is decreased in Parkinson disease, there will be excess of acetylcholine as well. So as we have to enhance the level of dopamine, Parkinson disease can also be treated with the help of anticholinergics to reduce the acetylcholine levels. Commonly used anticholinergic drugs are procyclidine clinically. And then another drug, that is amantadine. It's an antiviral drug. Its mechanism of action in Parkinson disease is not known, but mostly believe that it enhances the effect of levodopa on the postsynaptic receptors. And then a brief review of surgeries for Parkinson disease. If a patient is non-responsive to treatment, or if patient is having side effects of treatment of Parkinson's, then surgery can be performed. Two surgical options are available here. Number one is called ablation procedures. Ablation means destruction procedures. That is thalamotomy and pallidotomy. Thalamus is destroyed, specifically VIM nucleus, ventral intermediate nucleus is destroyed, and pallidum is destroyed, that help in reduction of tremors and rigidity. Then deep brain stimulation also helps in management of patients with Parkinson disease. Deep brain stimulation is more beneficial than stereotactic destruction because it's reversible procedure. It does not involve any destruction of normal brain structures. In deep brain stimulation, a lead is placed into the thalamus or internal segment of pallidum or subthalamic nucleus. Common target is subthalamic nucleus or STN nucleus in patients with Parkinson disease. And then transplantation of dopamine producing cells, embryonal cells into the brain. This is an experimental procedure not available in the clinically. We have learned about Parkinson disease and then a brief introduction about secondary Parkinsonism. Parkinsonism meaning then when there is a cause to the Parkinsonian features. There are features that suggest that patient is suffering from Parkinsonism. These features are symmetric onset of disease. Both sides involved symmetrically. As we have learned previously that Parkinson disease onset is always unilateral, but secondary Parkinsonism is symmetric in onset. Very rapid progression of disease. Parkinson disease mortality is around from onset to disease from death is around 10 to 12 years. But if the disease is progressing rapidly and death leading to death within 2 to 3 years, this is a feature of secondary Parkinsonism. No tremors at all also favor Parkinsonism. Autonomic features like urinary incontinence, urinary urgency at the onset of disease also favors secondary Parkinsonism. Frequent falls at the onset of disease also favors Parkinsonism. Then poor response to levodopa is also a feature of Parkinsonism. In the diagnostic criteria of Parkinson disease includes that the patient should be responsive to levodopa. If there is no levodopa response, then consider the secondary Parkinsonism in those patients. Then Parkinson plus syndromes. Number one is dementia with the Lewy bodies. The hallmark features of dementia with Lewy bodies is visual hallucinations, and then Parkinsonism. Memory decline is also a feature of Lewy body dementia, and then REM sleep disorders is a feature of Lewy body dementia. Progressive supranuclear palsy is uncommon, but the hallmark feature of progressive supranuclear palsy is vertical supranuclear palsy with downward gaze abnormalities. Postural instability or frequent falls is an early sign of progressive supranuclear palsy. So at the end, this is a case history of a patient. A 65 years old gentleman visits the OPD. He complains of stiffness and aches in his limbs. His son tells that he has become slow for the last few months. On examination, the tone is increased in the upper limbs asymmetrically along with the tremor of left hand. What is your diagnosis? From the history, we see that the disease is asymmetric in nature, so most likely, and there are tremors and rigidity, so it's a Parkinson's disease because it's asymmetric in nature. What type of hypotonia do you expect in this patient? Hypotonia is of two types. One is spasticity, other is rigidity. In patients with Parkinson's disease, we see rigidity, and specifically cogwheel rigidity because of the tremors. What other clinical signs will you look for? All other signs of Parkinson's disease that we have discussed previously. What are the different drugs that are used for Parkinson's disease? We have named six types of drugs that are used for Parkinson's disease and their mechanism of action previously. Thank you for your listening.